Did you know that antiarrhythmic drugs are classified based on their effects on ion channels and conduction pathways? Understanding how they work is crucial for both the USMLE and real-world cardiac management. These drugs help regulate abnormal heart rhythms by modifying the ion flow across the cardiac cells. In this episode, we will break down the four classes of antiarrhythmics, their mechanisms, clinical uses, and key exam facts you need to know. Let's get started. First, why do we need antiarrhythmics? Arrhythmias occur due to abnormal automaticity, conduction delays, or re-entry circuits. These conditions lead to irregular heartbeats that can be life-threatening. Antiarrhythmic drugs help restore the normal heart rhythm by modifying the ion channel activity and altering their electrical conduction in the heart. Key USMLE fact: antiarrhythmic drugs are classified using the Vaughan-Williams system, which categorizes them based on which ion channel they block. Class 1: Sodium channel blockers. Remember this term, slow conduction. Class 1A: drugs like quinidine, procainamide, disopyramide. They block sodium channels, leading to increased action potential duration and prolonged QT interval. It is used for atrial fibrillation and ventricular tachycardia. Their adverse effects include QT prolongation that can lead to torsade D point. And the drugs like procainamide can cause drug-induced lupus. The key here is quinidine can cause synchronism, a condition that presents with headache, tinnitus, and visual disturbances. Class 1B: drugs like lidocaine and mexiletine. They block sodium channels, leading to a decrease in action potential duration. It is best for post-myocardial infarction arrhythmias, especially in ischemic tissues. Adverse effects include neurological toxicity, including tremors and paresthesia. The key USMLE fact here: Class 1B drugs are the best for post-MI arrhythmias. Class 1C: drugs like flecainide and propafenone. They are strong sodium channel blockers. There is no effect on action potential duration, but markedly slow conduction velocity. They are used for supraventricular arrhythmias like atrial fibrillation or SVT. The adverse effects include pro-arrhythmic effect in structural heart disease. The key USMLE fact here: Class 1C drugs are contraindicated in post-MI patients due to their high risk of arrhythmias. Class 2: beta blockers. Remember this, slow AV node conduction. Drugs like metoprolol, propranolol, esmolol, atenolol, timolol, carvedilol. They block the beta adrenergic receptors, leading to decreased SA and AV nodal activity by reducing cyclic AMP and calcium currents. They are used for rate control in atrial fibrillation or flutter and SVT. Adverse effects include bradycardia, AV block, hypotension, and non-selective beta blockers like propranolol may worsen the asthma or COPD. Key USMLE fact here: esmolol is ultra short acting, making it useful in acute arrhythmias. Class 3: potassium channel blockers. Remember this, they prolong the repolarization. Drugs like amiodarone, ibutylide, dofetilide, and sotalol. They block the potassium channels, leading to increased action potential duration and prolonged QT interval. They are used for atrial fibrillation, atrial flutter, and ventricular tachycardia. The adverse effects of the drugs like sotalol, ibutylide, or risk of torsade D point. Amiodarone. This causes multiple organ toxicities, including pulmonary fibrosis, hepatotoxicity, and thyroid dysfunction. The key USMLE fact here: amiodarone has effects of all the four classes but has significant toxicities, so it requires regular monitoring. Class 4: calcium channel blockers. Remember this, slow AV conduction. Drugs like verapamil and diltiazem. They block the L-type calcium channels, leading to slowed conduction velocity and prolonged PR interval. It is used for rate control in atrial fibrillation or flutter and SVT. Adverse effects include bradycardia, AV block, and constipation, especially with verapamil. The key USMLE fact: avoid class 4 CCBs in heart failure due to their potential for cardiac depression. Let's learn about other antiarrhythmics. Adenosine. This increases potassium efflux, leading to hyperpolarization and decreased AV node conduction. It is used for paroxysmal supraventricular tachycardia, and adverse effects include flushing, chest pain, hypotension, and this can be blocked by theophylline and caffeine. The key USMLE fact: adenosine is very short acting, approximately 10 seconds. The last, magnesium. It is used for torsade depoint and digoxin toxicity. Let's do a quick recap and exam tricks. Class 1 sodium blockers, remember, slows conduction. 1A increases QT interval, there is risk of torsade. 1B best for post MI, and 1C contraindicated in post MI. Class 2 beta blockers slow SA node and AV node conduction. Class 3 potassium blockers, they prolong the repolarization and increases QT interval. Class 4 calcium blockers, they slow AV conduction. Remember, adenosine is a first line for SVT and magnesium used for torsade and digoxin toxicity. Now you have mastered antiarrhythmic drugs. Keep in mind the key drug classes, their mechanisms, and their USMLE tested toxicities, especially the risk of torsade with QT prolonging drugs and beta blocker contraindications. You are one step closer to acing your step 1 exam. Keep pushing forward. Thank you.